Anything could happen now. Shalom. Good evening from Israel. It's 10 o'clock in the evening. This is TMS Roundtable Global. We are around the world. We are in California. We are in Melbourne. And I'm going to just say I'm always happy to be here. Everyone knows I'm happy on a Monday to be here on a Tuesday morning with you, Rose, and you can introduce our guests.
Good morning, Tova. You know, when we look at pain, we have to actually see that it's actually a sensation that's been created, put together by the mind, by the brain. Now, Daniella Deutsch is going to speak to us about pain reprocessing therapy, or PRT. The whole concept is that we look at the biology of what created this so that we're affirmed about our understanding of how pain is impacting us and helping us to avoid our emotional life. So thank you, Daniella, for your time and your patience with two grandmothers here.
Thank you for your patience with me. And I'm so excited to be here today.
Thank you. Now, Daniella has got three little treasures, and she's a social worker by background. She has worked with Alan Gordon to actually put together some of the ideas or the concepts about why or how we manage to overcome the sensation of pain. Because in actual fact, we're not going to cure the pain, so to speak. We're going to actually put it in its place so it's not in the firm central part of our lives, and we're able to live our lives, and the need for the pain just subsides and goes away as we enter our lives fully. So please give us a little background about yourself, and then how this came about, and more so about how patients can actually grasp the idea that this therapy or any therapy that they engage in has to be a willpower thing. They have to will it to actually happen. And that was one of the lovely things that what I read about PRT is that desire to get better, the desire to live your life fully. So over to you, Daniella.
That was a really great introduction. Thank you so much. So as you said, I'm a social worker by trade, and I specialize in chronic pain. I'm the co-founder and content developer at the PRT Center. And at this center, I lead a lot of the certification trainings where we train and certify various medical and mental health professionals in PRT. I'm also currently involved in a PRT clinical trial and ongoing pain research, and frequently speak at different conferences and organizations internationally. And I'm here with you today, which is what I love to do. So how did I get into PRT? Why PRT? Why chronic pain? I mean, I've always been interested in psychology and what drives human behavior, what drives happiness and fulfillment, instead of someone who's lonely or depressed or in pain. And when I came across Alan Gordon, while I was in grad school and his center, I think that what appealed to me was this kind of results-driven treatment that really gets people out of pain, but also going to lead not only to less pain, but a more enjoyable and kind of fulfilled life, and that happiness and fulfillment versus loneliness and pain. But when I got into it, I think that maybe partially or maybe even fully, I was drawn to this work because I'm a very type A person and very results driven. And when you said, Rose, willpower to get out of pain, I think that I always grew up with kind of this willpower to push myself. And I didn't get sick, and I really was perfectionistic, always trying to get an A, like always trying to be great in school. And I think that this kind of personality that I have is a very similar personality to the patients that I work with, who are very results driven, very type A, have a lot of willpower, are very resilient and motivated. But unfortunately, kind of what drove me and maybe drives a lot of my patients in their daily lives is kind of fear, learned behavior, and different beliefs about their pain and beliefs about how they're supposed to live. And so that's kind of how I got into this work. And through treating a lot of my patients or working with a lot of my patients, I kind of learned myself to change that behavior, to change those beliefs, and to come from a place of love and care instead of just results driven behavior and type A personality and pushing and willpower,
That's a
So
form
that's
of
how I got
punishment,
here.
really, isn't it? Yeah.
Oh, yeah, I'm great at that.
Yeah.
But
Yes.
I want us all to agree, because I like to say that in order to change any behavior, don't we need to accept it first? Isn't that the path of
Yes.
death?
Yeah, it's kind of being aware of these behavioral patterns that you engage in that put you in that state. So I think with people that are in pain, it's kind of reinforcing the pain through different behaviors of fear or preoccupation with the pain, or, doing certain things to get rid of their pain. And those are the patterns that kind of keep them in pain.
That's right. Yes. Yeah. So then we created sort of a psychic explosion, don't we? And they recognize what's happening to them. Yeah. Could you talk about that a little bit?
So what's happening to them, it really is dependent on the individual. With some people, their pain starts because of an injury. And if it does start because of an actual physical injury, the body has this wonderful ability to heal. But sometimes with some patients, 2 or 3 months will pass and the body will heal, but they still go on to have pain every single day. And that is because of learned neural pathways in the brain that have learned to believe or, create associations between a certain body part and, there being pain or something wrong. And so the brain, just like we can learn how to ride a bike or we learn how to walk, we can learn how to experience pain in certain areas of the body.
That calls to mind as you speak about pain management. Pain management is sort of like working around the pain, whereas PRT is more about living your life and forgetting about the pain and recognizing that it's a symptom rather than the cause. So, yeah. Thanks,
And I
Daniella,
remember,
for that.
I love what Alan says. I took the course. I've been very blessed to take the course. And just like Rose teaches me a little ISTDP, I'm teaching her PRT. So we're learning from each other by osmosis. But Alan says in the course that neuroplastic pain is counterintuitive. And it's pain means something's wrong. Something's wrong. Do something. Fix me. I'm broken. But it's
Yeah,
not.
but it's a heartache.
Yeah. It's not the way it is. It's actually, and it's so different than what we're learning. So we are sort of, not only are we trying to help people, the three of us here, in pain, but we're having to break down, or what Rose will call scaffold away, or peel the onion of conditioned response. Something's wrong with me, and getting people to believe that it's a sort of psychological. This is another whole big part of our education, is just to undo what the system's done. And again, many people are getting better with medicine. Great. If you're getting better, then you're not here listening. So
that's right.
It's a little bit more, it gets a little bit more difficult depending on the patient, like you said, but it is counterintuitive. And I'd love you to chat about that, because it'll help our listeners understand that we have to approach differently and have a new language and a new relationship with our bodies and pain.
Absolutely. I mean, that's exactly right. We're evolutionarily hardwired to associate physical pain with physical damage. So it goes against everything that we know when we say, okay, I'm having pain, but that doesn't mean that there's something wrong with my body. And so it's kind of having to unlearn that idea of just because my body is in pain doesn't necessarily mean that there's physical or structural damage. And I think that's something that kind of sets us apart from just acceptance therapy, which is, it's not just, oh, I'm going to accept the pain because the pain is going to be with me forever. No, I'm going to change my belief about the pain and where the pain is coming from. And because when I believe it, then I will no longer, the pain circuits in the brain are going to turn off, because pain is really, a combination of both our internal predictions about what is going wrong in the body and sensory input, right? So it's not just sensory input, if it's dangerous, pain. It's sensory input plus our brain kind of making meaning based on past experiences and expectation and learned behavior. And that is kind of what produces the pain experience. And so if we can change the belief and we could change the expectation, then our brain will no longer generate pain when there is no structural damage. And that's the premise of PRT.
Okay. So how do we change the belief? Can we have an example?
Sure. So let's say, I once had a patient who he was a soccer player, and every time that he kicked the ball, he had pain when he's playing soccer. And originally he had an injury, but it healed and his brain learned to experience, it's a kind of condition kicking with pain. So what I did with him is first we talked, I provided some psychoeducation about pain, about what is pain, why do we feel pain, and gave him some studies about people or give him some stories. Do you ever hear the story about the construction worker?
Yeah. Oh, yeah, yeah.
He stepped on a nail.
I made a whole PowerPoint around it. Yeah, yeah.
So there's this construction worker. It's like a really famous story.
The nail in the boot.
Yes. And he's at a construction site. He steps on a nail. He's in agony. He gets rushed to the hospital. They pry off the boot and they recognize, oh, wow, the nail went straight through his toes and didn't even cause a scratch.
Between his toes. Between his
toes. Like didn't go through his toes, went straight between. No scratch, no injury, nothing wrong. Yet his brain produced, pain to warn him of a threat based on just the belief that he was injured. So this is kind of some of the stories that I'll tell my patients as we're going through this psychoeducation piece. Then the second step of PRT is let's gather evidence that, this is not indicative of physical damage. So I'll ask questions like, okay, is the pain always there? Is it there every time you kick? Is it worse at night or in the morning? Are there any points where you notice, it's worse when you're more stressed out? And kind of like with my patient, we'll put on these detective glasses or a magnifying glass, and we'll look for clues that the pain is not actually indicative of damage. So that is the cognitive way that we approach it. How do I work with the logical brain of my patients? But then there's the next step, which is how do I work with their kind of primitive brain? And I know a lot of people say, okay, there's no such thing as a primitive brain, but let's just call it that for now. But to work with the primitive brain and to show the primitive brain that it's safe, let me do an exercise with this patient who has fear around kicking and leg pain. So together, something called somatic tracking. And, I'll have my patient, I literally went with him to the soccer field and he kicked the ball. And with each kick, I said, okay, now we're going to regulate. And what do you feel while you're kicking the ball? And I try to make this safe environment and use mindfulness and safety reappraisal. And I try to make it a really positive experience. And then he'll get a corrective experience where he sees he's kicking the ball, but there's no pain. And that shows his primitive brain, oh, not every single time I kick the ball will I experience pain. It really is a matter of what is my emotional state when I'm kicking the ball? Do I feel safe? And when we talk about safety, it's not only, safety or unsafety around the symptoms themselves, but what are other things in our patient's environment that might be making them feel unsafe and therefore interpreting things through a lens of danger? So what else is going on in this boy's life, this soccer player's life? What are his parents like? What is his childhood like? What's his social situation like? And then you can find more clues into what is making your patient, in a more hyper-vigilant state or more hyper-aware or more likely to interpret things as dangerous when they're not. Does that make sense?
Yeah, of course. Yes. Well, what you're doing is you're building their reflective capacity so that they can observe. So by observing, they can then decide. And that's where the willpower comes in, that they're so strong with, because the willpower to see it for what it is, as though you're an observer. Or, you could even sort of say they were a drone and they were looking down at all these patterns that have happened to them and have been consolidated. And, for anyone watching at the moment, Michael Galinsky's movie All the Rage is sort of that person's journey through this. So just to put that little, what would you call it? Add in, what would you call it? Yeah. because that journey, you have to observe it before you can actually change it. And I think that's the aha moment for people, isn't it? Observing it. This is the pattern that I've been hanging on to
And
for
not being
safety's
attached to
sake.
it, right?
No,
And
this
not
has
being
been my
attached to it.
safe place to have pain rather than
Mm-hmm.
no pain, because it's unsafe without pain, isn't it? Yeah.
Absolutely. And I think that that's a question that I ask people a lot. It's like, okay, well, what would your life look like tomorrow if you didn't have pain?
Exactly.
And sometimes it's not a great response. Sometimes
It's not, is
more
it?
fear. No.
Yeah. Well, you know what? And I wouldn't have learned this. I wouldn't have learned this with my work in my field. And then I learned a lot from Rose, that when the pain starts to go down, the anxiety comes up.
Mm-hmm.
And then we'll say to people, well, do you want to choose one or the other? Because you're going to, the anxiety is a place where we can really work with now and really go deeper and really own and know yourself and understand that the anxiety is not here to hurt you. It's the same sort of, we can do somatic tracking with anxiety, but it's interesting how the pain will go down and anxiety will come up and people will be like, I want the pain back.
I think it could be a lot scarier to look at yourself for who you are. I think that once your defenses are down, it can be a lot scarier.
It is scary. Yeah. And you probably don't bring in that early attachment model within your therapy, but that early attachment is so important to how we view ourselves. So yes, yeah.
I mean, I love attachment theory, so I do bring it into my work, but
good.
it's not technically part of PRT specifically.
No.
But I like attachment work, so
yeah. Well, it is
I use it.
a very prominent thing in ISTDP. So yeah, because we need to undo the early attachment trauma.
Well, the feelings, I mean, it's such a biggie. It's such a biggie with the fear. I mean, that when we all have sensations. I mean, I learned this from Alan. We all have sensations all over. We could all find 20 sensations in our body, especially sensitive people. There's a spotlight on it and you're just zeroing in. And then if you add fear to it, it'll equal pain.
Mm-hmm.
So here you go.
I know we have this equation of fear equals sensation. Pain equals sensation plus fear.
Right.
Yes.
And
well, that
once
movie
you can get rid of fear.
shows the little daughter being terrified of the injection or whatever, and she's crying in pain before she even gets the injection. Right. And it's a really good visual of
Michael's daughter getting a shot.
Yeah, actually, will you put that on the side for anyone new that hasn't?
I will.
Yeah,
I will. I want to say that about something about fear because so we actually met Dr. Bethany Rains, and she had done a podcast for Curable about pain as an emotion, and we've had her on our show a few times. She's this amazing scientist who loves helping people with pain and helping understand the neurological. And she comes from a very scientific background, but she breaks it down for us the few times she was on our show. And I promote this concept, and she said it in more ways than one, that pain is processed in the same place as fear and anger and sadness and shame. And so pain is an emotion.
And love.
Mm-hmm. Can you talk about talk more about that? Because it really ties in, the fear factor, the anger factor, the possible adverse childhood experience factor. It all brings in the trauma, the emotions, and we get to really heal it. PRT can heal a lot of things through that lens.
Well, yeah, I mean,
can you talk about that a little bit?
Sure. I don't think that PRT is specifically only for pain. I think you can use PRT to help with any misinterpretation of something that's dangerous. So whether that's, conflict or whether it's pain or whether it's intimacy, whatever it is, whatever your brain is misinterpreting as dangerous, we want to help your brain interpret it as safe. And that's is that the question that you're kind of asking?
Yeah, I mean, not only do I use somatic tracking and PRT with autoimmune symptoms, but I'm also using it to help people calm their brains, stay in their parasympathetic nervous system, activate their vagus nerve, which creates inflammatory and, your own cocaine and your own cannabis and your chemicals, because I think we're dealing with the brain and emotion. So we're really breaking it down to the parts of, because fear is motivating most people's pain. So we got to deal with the emotion.
Absolutely. And what I think is really interesting is that, like you said, pain shows up, and not all pain, because acute pain will show up in a different part of the brain, but chronic pain shows up in the prefrontal cortex, or where there's learning, there's meaning, there's all of the other things that you mentioned, Rose. And so chronic pain is a very emotional experience, and it is very rooted in the way that we make meaning, and our past experiences and learned behavior happens from past experiences, which can be past traumas. So our fears are rooted in the same place that the pain is rooted.
Yeah.
Amazing.
So tell us about the course that you do for therapists.
So the course is a 21-hour certification program. Half of it is video, like asynchronous material that participants can watch over the week, and then they meet every Sunday to practice, to kind of just do different discussions, ask questions. And after this 21-hour certification program, they become, PRT certified, either coaches or doctors or OTs, PTs, and they're listed on our PRT directory.
Oh, lovely. And you're now going to do a course. Tell us about that for patients.
So right now we're creating a group called Healing Workshops, and those are going to be 8-week healing workshops. It's 1.5 hours per week in a small, intimate group facilitated by a PRT expert. So we're really excited about that. Mm-hmm.
Yeah. Well, Tove and I have done that over quite a few years, haven't we?
Yeah. We're you're going to be doing it on Zoom or in person?
Zoom.
So, and it's funny because when I took the course and when I listened to Alan's book, I know he is in person helping people with their pain. Like, I'll have them get up. I know he went to the pool to meet a woman who was scared to get in the pool. And so I'm doing virtual work with a lot of people in the States. And I say to them, take me on your walk, put on your headset, and I want to go. Or this woman, she was even in Israel, but she lived far away from me, and she would get dizzy when she would get in the car. And I would say, I want to come in the car with you. So I think it's very possible to be virtual and do this, because I call it like a mindful moment, like, because and I love what Hanscom calls safety threat physiology, which is not so much PRT, but it's all the same umbrella as that, the body's perceiving a threat that doesn't exist, and we need to bring it safety. It'll be the same thing with what Rose will do with ISTDP.
Yeah. Well, that's why I think that willpower is so important. That willpower that they've had for defiance or compliance or whatever, to use that for your healing, for you to see.
Absolutely. Yeah. I just think, it's so tough, because I know that a lot of my my patients who suffer with, from chronic pain, this idea of willpower to them, or pushing through, a lot of times will keep them in pain. And it's trying to figure out, how can I motivate a patient to intervene from a place of self-love and self-care, instead of intervening from a place of myself, self-punishment and
bullying,
that inner bully. And it's tapping. That's usually the first step. It's not the goal is not to get someone out of pain immediately. The goal is not to make it go away, right away, to get a corrective experience immediately. But how can how can we get our patients to relate to themselves in a kinder way and actually care about the fact that they're in pain and not just, I need to get out of it because this is ruining the way that I'm treating, able to take care of my kids, or the way that I can work, or the way that I can succeed, because then it's just another way of reinforcing this fear in their lives.
Yeah.
Could we go back to our soccer player? Because that's a lovely example. And talk about how he presumably had a sort of self-punishing mentality, and how you change that, because that's that willpower thing is to change, isn't it? To get that aha moment, to see how I've treated myself. Could you use him as our example so that we've got a particular body of experience that we're talking about? Yeah.
So for him, it wasn't the classic. It wasn't the classic example, because as much as I kind of dug into his family life and his parents, what I understood about his life, because he was a teenager. This is a teenager that I worked with. But what I understood about his life and his childhood is that he had really loving and supportive parents. And so I kept on being like confused. Why is this person in pain? Why does he put so much pressure on himself? What's going on here? Why does he need perfection? But the more that I learned about him, the more I realized how much he looks up to his parents, who are extremely successful. His father was also a soccer player, was also really, really athletic and really successful. And it was kind of this self-imposed pressure to live up to, these standards that his parents not intentionally kind of put out into the world without even knowing. And so it was getting into the idea of like, okay, so let's call him, I don't know, just think of a name, Josh.
Yeah.
Okay. So, Josh, like, what do you love about soccer? Do you want to be playing soccer? Do you, is this something that, makes you happy? And the more that we kind of dug into things, yes, he liked playing soccer. He didn't want to stop playing soccer, but he didn't want to only be known for and only be loved for excelling at this sport, right? Yes. And it was about how can I get him to relate to this sport with a little bit less high stakes of an attitude. Like, I need to excel. I need to be the best soccer player. I need to be as good as my father. I need to be as, successful as my mom, in order to be a successful person. How can I derive feelings of fulfillment and success outside of just soccer? Who am I? What is my identity outside of soccer? Mm-hmm. And I think that sometimes the pain can come in and warn us of a threat, but the threat isn't necessarily that the leg is damaged. The threat can be, I don't feel like I'm in touch with myself. I feel like I'm far from, understanding what I need and what my needs are. And for him, the need was to be able to get love and understanding outside of just being a soccer player. So it's not the typical example, and it's not big trauma, but it's a little.
Okay. Mm-hmm. The thing is that trauma can be small and it can be large, and it's all trauma. So it doesn't really matter. And the trauma in that boy's instance is not so much that he's been punished, but he's actually taken punishment on himself because he's not as good as dad. So it's the same concept, but just from a different angle. Yeah.
Would you say he had a very unhealthy relationship with himself?
Yeah.
And didn't like himself? Could it be simple?
Yeah, because he compared himself to dad. So once he compares
Right.
himself to dad, he's not good enough.
It's a losing game.
So yeah. It's so common. Yeah.
So we're back down to compassion and the science of compassion and self-love, which you mentioned a few times, Daniella. And how do we? I mean, I can think of a few people that Rose and I know that I've worked with, or Rose has worked with, that they just think it's hard for them to love their bodies. And I say you sort of have to feel love in order to. You have to accept that you can even accept that you don't love your body, and the brain will calm down. Okay, I don't love my body, but I know my body's doing the best. Like, you have to have some sense of a bridge So how does somebody in so much pain with so many symptoms they feel attacked, or how does somebody get to a place where they can feel like they can love themselves? How would you treat someone? What would be your steps that you would take?
Again, it's so different with each person, and how can you get someone to build self-compassion? With the moms that I work with, I'll use their children and say, well, what would you say to your child if they were struggling with this? Maybe it's, inner child work, which is definitely not new to PRT. It's, can you imagine a time where you were a child? What would you say to your, inner child? But sometimes it's not that simple. I think that for a lot of my patients, rejecting themselves regularly and their needs for so long, it's hard to, I'll ask, like, okay, so, well, what's your relationship with self-care? And they'll be like, what's self-care? Yeah, I guess sometimes I'll go for a run, or I will, and they're usually these really intense self-care activities.
Yeah.
Like going for a 6-mile run every single day. I'm like, oh, well, do you enjoy that? And so, and these patients can be really intense. And how does a sense of intensity contribute to, these danger signals that we have? These danger signals that we have, such as pain or anxiety. How does it amplify those different signals?
Yeah. Very good point. Very good point. So what, it reminds me of this patient. I spoke about it last week. We had Michael Galinsky on, and in fact, speaking about tattoo, Michael, there was something Michael had. It was a baseball player, and he had a psalm, actual psalm on his chest, like psalm. It was like a Jewish psalm written on his chest. I just love tattoos. I mean, I had a patient who had on the back of her neck, like just trust. Or I was in IKEA, and a guy had on his arm, only God can be the judge. I'm like on his arm. So there was someone I contacted last week. I saw his Facebook page, and I contacted him because the tattoo was "Life is pain," and it was dripping like blood from the letters. And I spoke to him, and I really wanted to turn him on to this work. And he had a failed spine surgery, which I think could definitely benefit from this work. And we've seen it in Love Heals, which I sent you the movie, and we're seeing lots of different situations. It's not just, doesn't have to be simple back or neck pain. And I said to him, what's the message of your pain after he spoke for a while? And he said, my body won. Like my body beat me. And, you have to sort of, and like if his doctor would have just said to him, look, I'm sorry the surgery failed. I'm really sorry it didn't work. And we know that there was something about this man's personality that probably that it failed even more. Let's say the doctor said, I'm sorry that it failed. Maybe there's still hope. Like,
and
that's
then,
just,
it kind of gets me to ask a further question of, okay, well, if this guy would have really believed that the surgery would work, and he almost in a way willed himself to believe that, it's possible that the surgery would have worked.
Yes, exactly.
And it's so hard because when you're working with beliefs, it's really hard to change someone's intrinsic belief. You can change beliefs on a logical, intellectual level. You can say, I believe that I'm safe. I believe there's nothing wrong with my body. I believe the surgery will work. But do you truly authentically believe it? And how can you get someone to change their systems of beliefs? And I think that's the hardest thing. Is like, even when you're just talking to regular people about regular thoughts and regular feelings and, whatever, nothing to do with any of the things that we're talking about. When there are two people who have two different belief systems, it's like, that is the hardest thing to change about a person, is their beliefs, especially the longer they hold those beliefs. They become so strongly rooted.
Yeah.
And so it is very hard work when people have this strong belief that there's something wrong with their bodies. How can we change that? How can we start to chip away at that?
How?
Slowly.
Go ahead.
Slowly and patiently, and, with love and with care. And it's not easy. You know,
Well,
with some people,
we can tell them, look, it's the story they tell themselves. So
right.
it's not their trauma, it's their experience of their trauma. So we can talk to them more and more about, this is your experience, it's your thoughts, it's energy. If you want to get down to the bottom of it, it's quantum, and you can change that. That's why NLP is working for people. That's why, narrative counseling is working for people. People are realizing that they've been telling each other lies. I mean, how Byron Katie is so popular, and her work ties in with our work. Like, you're believing your thoughts. Let's question that thought.
Mm-hmm.
Yeah.
But even
Well,
further than that, I feel like the strongest way to change a belief is to actually give proof that it's not true.
good. That's where I'm coming from. Changing the belief is about giving the proof. Yes. How can you validate that? What's the background that you believe that that's the case, that you're not fixable? No, my mother always told me. Okay, so was your mother right? What validated her to be able to say you're never going to be any good at mathematics? Because your belief is her belief, isn't it now? How does that work? Are you going to live for the rest of your life in your mother's belief or in your own belief? Yes?
Good one. Good, Rose.
Yeah.
Yeah.
Yeah. So that's how
You
we change
believe
it, isn't it?
Exactly. Exposing them to the thing that they're most afraid of, which is kind of classic exposure, and showing them what they learn to fear is actually safe, and giving them the evidence and saying, you see, your belief was wrong. And slowly, the more corrective experiences they get, that what they feared is no longer, is not actually dangerous, the more that they will believe it, the more we can change the belief. And I always say to my patients, you don't need to 100% believe that there's nothing structurally wrong with you at the very beginning. You're not going to fully 100 believe until you're completely out of pain.
Can I tell you something, what I do? I just go in the back door. I don't worry
Let me
about
hear.
the beliefs or not. Go in the back door and see how this kitchen operates. Yes.
Give us an example, Rose.
An example?
Yes.
I just gave you an example.
Okay.
Yeah.
True.
I'm not good at mathematics. Oh, really? So who told you that? My mother. Oh, okay. So her belief fits in for you, does it? Yeah? Is that how it works? Whatever she thinks is what you think. Yeah? How's that going to work for you for the rest of your life? Well, I never looked at it like that. I never saw it like that. Oh, okay. So then that aha moment comes about and they can see. I mean, I've condensed a whole bunch of things, but by just going to the back and helping them to see what's going on, then they don't have to believe or not believe because it's there in front of them. Yeah. So that's just.
But what's ironic is that even
story.
but what's funny is that even when you prove it with 100% certainty, it still doesn't always sink in.
That's right.
It takes
You've
time.
got to go back and back and back. And you've also got to remember what they actually told you a week ago or a month ago or 6 weeks ago. Yes, isn't that what you told me before about X? Oh, okay. So if that is what you told me then, what's happening now? So they can make the link to the past and integrate it. And then, of course, it loses its energy and they don't need the pain. Yeah. So, yeah, that's just a little nutshell.
Exactly.
Of ISTDP.
Yeah, like one simple technique that we do is we just have them write an evidence list. Every time they get a corrective experience, every time they get evidence that the pain is not actually structural, that the pain is based on, belief or neural pathways in the brain, we have them write it down so that later on, when a pain spike hits again, because it always does, it never goes away forever, they can pull out their evidence list and say, wait, I have all this evidence here that my pain is not rooted in physical damage. And I have proof.
Yeah.
Yes. Yeah. Well, you see, that's why I don't actually ask about the pain. I ask about what's going on in their lives so that then I can move them away from their pain and into their lives. So, like that belief system, for example, is not about their pain, but about their self-belief. And if I can crack that open, it's almost like a cement block that a person has in their diaphragm. And all we do is we put a little jackhammer in there and shake it up so that we can actually allow the feelings to come up and break away from that whole concept of what someone else told me is who I am, rather than who they are in themselves. So, yeah, that's why.
When you work with pain patients, you don't talk about the pain at all?
Not really, no.
That's pretty
Because
powerful.
that's a symptom. I want the cause. It is. It's amazing. It's amazing. Yeah. Remember that the pain is the smoke, but we want to go to the fire and put out the fire. And that's why I sort of use that kitchen example of going in the back door. The patient will tell me all about their pain. And again, as you say, I ask them when it occurs, how often it occurs, is it transient? I ask them all those sort of questions. And then I ask them what else is going on in their lives. And then I've got a formula of relationships, self-esteem, work, peer pressure, all that sort of thing. Exactly what you're telling us about. So we're all
it definitely overlaps. Exactly.
Oh, yeah.
It definitely overlaps a lot.
Yeah.
I think that a lot of people who come to us, when it can take some time before we can get into what's going on in their lives, because a lot of them are so motivated to only work on the pain that we need to first take the step of convincing them why it's worth diving into the other things and how that will relate to their pain. Because if I want to talk on the first session about, okay, well, what's going on in your lives, I'll have some patients who will be okay with that. But then I'll have others who are like, well, this doesn't have to do with my pain, or I just want to get better. And I have 6 weeks to get better. And I'm only doing 6 sessions and it needs to be gone. So it takes first. I have a first step that I need to get to before I, even, because I think that, how do you get your patients when they come to you? Do they know that they're doing ISTDP or?
Not necessarily. No. I mean, I'm friendly. I'm open, And
I guess I'm not.
No. I'm just open, friendly.
Some of the patients are scared of you. Come on.
Do I look scary? But you see, what happens is our attachment model comes up in the room. It's our attachment model that creates the scariness. Because once you look into a person's eyes and you have that sense of compassion and love for them, they get scared. It's normal. If you've had a scary experience with people you love, you're going to be scared with someone who's going to be caring. That's why, yes, they've come to me with symptoms, back pain, etc., or fibromyalgia, whatever. But then after hearing that, I always ask, what else is happening to you? Have you had a loss? Are you grieving about something? All of those other things, so I can bring it into the picture. And then it sort of settles them a little bit. Yeah. And as Tova mentioned before, I try and scaffold the person, which is what you do. But I've got different terminology for it. That's all.
Yes.
Yeah. And what happens and like Rose's, the clients of Rose will they'll feel worse. And we know it's an extinction burst. It's there. And, and I'm always like, it's a good thing. It's a good thing. And stay with it. Trust the process. And the extinction burst for any of our listeners is that, to explain it to me, I like Alan's explanation. I don't say it like him. How would you explain an extinction burst, or when someone feels worse after having a session talking about their feelings? What's happening, Daniella?
Well, I think it's the last ditch effort before the behavior is no longer reinforced. So
exactly. Yeah.
If you're treating your pain.
But I like that. Say that again. It's the last ditch effort before the behavior. Say that again. I like it.
It's the last ditch effort before the pain is no longer reinforced.
Okay, so
it's before the pain is extinct. Exactly.
So
It's like, let's say
yes.
every time they have pain, right? Every time they have pain, they say, I need to put an ice pack on it, right? Every single
Okay.
time. Oh,
Okay.
we have a question here, but
Yeah,
every
yes.
single time they want to put an ice pack on it, right? And every time they do
Yes.
the exact same thing. But then maybe after, undergoing some treatment of, PRT or ISTDP or whatever they're doing, when they have this pain, instead of going for the ice pack, they do a little bit of somatic tracking. They watch the sensations. They do some safety reappraisal. They don't go for that ice pack. They tell themselves that they're safe, that there's nothing wrong with their body. And the pain starts decreasing and they start getting evidence. They start getting proof that there's not a physical problem. And they do it over and over again and their pain is gone. But then all of a sudden, there's a pain spike and the pain comes back. And to me, that is that last ditch effort. It's saying, oh no, it's like that rat in the pellet that, the rat, and every time he presses for the pellet, it comes, and then all of a sudden it doesn't. So you would think he would stop pressing, but instead he presses harder. You're like, oh my God, the pain is back.
Okay,
like I need to quickly.
Wait. So this is amazing because there's someone I'm thinking about, and she's just this lovely, lovely, lovely person. And she'll work with Rose, and she'll feel a lot worse. And sometimes, so what's happening? What's happening to these people? What's when they feel worse after just talking about themselves or pain or their feelings? What's happening?
Well, I think that's something that
say it again.
Yeah.
Yeah.
Mm-hmm.
It's just
I want you to say it again. What's happening is that their body is holding weight. Their body's holding on to the pain. Their body's say it again. I want to understand it from your vocabulary. What's happening when they're in more pain by just talking about their situation or their life? Why is the pain getting worse? What's happening again? I want to hear again.
From whom? From
I want to hear
Daniella
from
or
either.
me?
Yeah, I want to hear. Let me hear Daniella first because I want to understand. No, because I think it's it's important for people to know because then we can talk about like the expectations. Like we're not always going to be. You're not always going to be out of pain or feel better after a session.
Okay.
But
Can I go first?
Yes.
Go.
If we've got loving feelings coming up about ourselves or our family or whoever, and those loving feelings could cause fear, well, the pain's going to come back to warn you that the fear is imminent, and that if you go any further with loving feelings, it's going to become difficult for you. So loving feelings come up, care for someone, loving feelings, and then the fear comes up. And that's why I like the connection to attachment theory, because that fear is like that Edtronic video that we show people, that the child gets fearful when the mother turns her face away. So that old fear, that old pattern that Danielle is talking about shows up in so many ways. Or Michael Galinsky's movie, it shows up, the old fear shows up to hit. And of course, it's dangerous to be caring. If you're in your intimate partnership arrangement, if you want to talk about money and they don't want to talk about money, what are you going to do? You're going to shut down, as though when mum and dad couldn't talk about money, I'm not going to be able to talk about money in my relationship. So the pain will come up to block the warm feelings about talking about, I don't know, the future or the holiday or whatever. So the warm feelings have to be subdued, and pain is the method to do them. And that's why Bethany Rains is so important. That whole concept is all intertwined. And, I often think about all those feelings as being knotted. And what we're doing is we're unknotting them. First of all, as Daniella says, we point out that the pain is coming from an area in the brain or the mind that won't gel with everything. So peel it all back like an onion. Peel it back so that we can get to the heart. And of course, it's the heart that's hurting.
So the person's pain is increased because they're getting
warm feelings or feelings of safety.
Or
feeling of safety will bring
another
fear.
Yes. That's absolutely. Or feelings of, I think that some people, for example, with their pain, they're very preoccupied with their pain symptoms for a really long time. And it becomes, what we call it like a default setting. It becomes a thing that they're the most used to. And so, even so when they get better, they still have this preoccupation, but they don't know what to do with it. And it becomes scary to not have anything to do with it. And when they're no longer in pain, it's like, I've been preoccupied with pain for so long. What do I do with all this
Where's my
preoccupation?
life? Your life has sort of flown away. And
And I think that it brings into question identity. It's okay, what am I without my pain? Or what do I do with myself without my pain? Or, what do I busy myself? And then, yes, I see safety, like you said. I see safety and I see stillness and I see calm. But that doesn't feel safe to me because it's not familiar.
That's terrifying. Yeah.
Oh, right. I got it.
Yeah. And also, when patients have safety and calm, they're waiting for the storm. And the other metaphor
Like
that
it's
I
not
like
going to
to
last. It's not going to last. I
Yeah.
don't deserve to be better.
That's right. Yes.
Or I'd rather be hypervigilant forever so I can just, because the next shoe is going to drop. But if I'm hypervigilant all the time, then I'm going to catch it. But that's not the reality. Right. Actually, if you're hypervigilant, you're more likely to interpret something that's safe or neutral as dangerous when it's not. So
exactly. Say that again, Daniella, please. Very important.
Oh, no.
Slowly and
okay. I mean, I can use a little bit of a metaphor that I always use, which is I call it horror film mode. Like, when you watch a horror film, you are in a very hypervigilant state. And so after you watch this really scary movie, every little house noise will send you into a frenzy. And you'll be like, oh my God, there's an axe murderer around the corner. Like, oh my goodness, I need to run. And I think that people who have been in chronic pain for a long time are in this constant state of like, I'm watching a horror movie. Like I'm constantly hypervigilant for when the next thing is going to jump out at me. And it's because they have this belief that something bad is going to happen. But it's almost a self-fulfilling prophecy, because if you're constantly hypervigilant and you're constantly looking for the thing that's going to be bad or painful or negative, you're going to find it. Because you're wearing that lens, you're wearing that danger lens. So you're going to interpret things that are neutral or safe as dangerous, even if they're not.
Potentially dangerous. Yes. Could I also add to that the anxiety that's in the muscles? When you think about danger, I think about fibromyalgia, for example. We'll use that as an example. The muscles are tense as though you're on the starting blocks all the time, waiting for the danger, waiting for that horror movie to eventuate. So you've got to be there on the starting blocks. So this muscle's going to go, that muscle's going to be painful, the hip's going to be painful. All of those things are going to be painful because the person's on the starting blocks completely.
Because you're bracing for impact.
Yes. Yes.
You're constantly bracing for impact. And, I have this colleague who used to play rugby a lot, and she used to get injured playing rugby. And her doctor told her that it's because she was constantly bracing for impact. That when she got hit, instead of just being like this like loose person being hit, she was like a rock being hit, and it would crack in the middle basically because of how she braced for impact constantly. Wow. And I think when there's tension and bracing, you can experience pain, even if it's not the root cause. The root cause is the anxiety and the bracing and the hypervigilance, not the physical problem.
Yeah. That's right.
Yeah, good point.
That brings me to another point. I often hear about people that have got torn ligaments. And, after doing ISTDP training, I thought, the muscles are all tight. The muscles are the ones that are allowed to fray. But if you're tight, your ligament's going to go because the muscle won't be flexible. So the ligament gets torn off the bone. And, I often, when people say to me, I say, well, what else was going on when that happened to you? Oh, well, I had a fight with my husband that morning or whatever.
Right.
Yes. So your muscles are going to be tight. So your ligament's going to be torn. Yeah. Or your soccer player, for example. He's so tense of wanting to prove to mum and dad that he's as good as, and instead of the pain happening, his ligament goes because his muscles are so tight, they're not flexible enough to allow that impact to happen. Yeah. Anyway, that's just
no muscles. Listen, they call them the orphan organ. The muscles. They're for me as a chiropractor, 36 years. The muscles are always the culprit, and the muscles hold our memory. So it's so body mind, and but I want to say something, but I want to forget. Cheryl leaves these beautifully rich comments. Rose and I helped Cheryl. She had every itis you could name. She was a stewardess,
flight attendant
for many years.
Yeah.
Can you imagine the life of a stewardess? And then she came on our show after Rose and I helped her, and she really spoke beautifully. So she leaves these beautifully rich, long statements. I don't think it's a question, Cheryl. Are you asking a question, or are you just talking about, anyway, the true power of belief is the master of the mind, the one with no sound. Such a poet. Cheryl, so good to see you here. And anyone else that has any questions, we're going to round up in a few minutes. There's a bunch of people watching, but people.
Oh my God. Isn't it funny how that hour goes so fast?
Yeah, people can be very shy, but I want to say that that this video will be on our YouTube, and we have a lot of wonderful subscribers to our YouTube. I really I think, before PRT sort of had the name, we were sort of all-knowing somatic tracking, which was sort of a buzzword in the mind-body field. And I wanted to chat for a minute about, because we are exposing people to the pain. So I want people to be clear that we're exposing them to the pain so they can be friends. They can, what I call, have a love affair. They can be, I'm safe. This pain is just a sensation. Like, chat about that a little bit so people can understand what's
not
happening.
To be afraid of it.
Yeah.
Well, I think that the ultimate, and I think it's hard to say in the beginning when someone is really in the throes of chronic pain, but I think the ultimate goal is what you're saying, to be friends with your pain, to be friends with your body, to be able to turn to your body for clues about profound inner struggles, to be able to take those danger signals from the body and not to think, oh, there must be something physically wrong with my body, but oh, there's some other threat in my environment. There's something else that's making me feel unsafe. And how can I take care of myself in this moment? Whether that's just taking a self-care day, or whether that's creating boundaries with people, or whether that's, doing something for yourself intellectually, or whatever that is, but using your body as your guide, that it's feeling unsafe, and then respond to it and take care of it before the pain has to act out.
Yeah. In other words, respond rather than react to whatever's going on. Yes.
Really beautiful.
I love how you say it so practically. I go on this whole spiel and you're like, okay, so then basically respond instead of react. Like, precisely.
I love it. Well, anyway, if you were to leave, Danielle, if you were to leave one, what I call like take-home tool, like, though Rose and I don't like to use the word tool because people are not broken, but it is a psychological tool, or one insight. What would you want to leave with our listeners and the people who are going to listen to this on YouTube? Like, what would be a sort of like a bridge that you can give them to either, tell me, like, to keep hope and to keep up the willpower and to not give up, because this is the way out. And I think the way through, even more than the way out, is the way through. I was listening to Alan Gordon. I have the book on audio and I play it a lot. And he wrote this, he named it The Way Out because his chronic pain was unbelievable. He had, Rose, he had, like, you cannot believe, diagnosis after diagnosis after diagnosis, and headaches and migraines, and enormous, like, and he said he named it The Way Out, because of how he came out of it. So what would you want to leave our listeners tonight?
Well, I think there's a lot of hope in PRT and the work that we're all doing, whether it's PRT or something else, in that the same way that our brain can learn to experience pain in the same way that we can have these belief systems about our body or about anything else. We can change them with proof, and we can rewire, neural pathways in the brain by creating new ones. And I think that that can bring a lot of hope to a lot of people. And no matter how long you've been in pain, and no matter how long you've had certain beliefs, you can change them.
That's right. Yes. Yeah. Yeah. And that's what brings me to this aha moment. Yes, to stay with looking at it, observing it, seeing it as though you're a drone, looking at your belief system. And what's the evidence of that belief system?
Beautiful.
Yeah. And then the body can heal itself. Yeah. The suffering. Yeah.
So much wisdom.
Daniella, it's so lovely having you. And Tova will
Thank
put
you.
some information up on, because she's the custodian of the
Yeah, I'm the techie.
sidebar.
But no, I
Yeah.
put up a big thing from the website. I put up a
Oh,
big
good.
blurb, and then it brought up Alan's book, which it's just it's well written. And someone even said on the Facebook page, his audiobook, it's his voice, and he has a very calming voice.
True.
And he has some great stories between the Lakers and the Philadelphia 76ers and Tina, what's her name from Saturday Night Live, and he has great stories. And it's a very wonderful book. It's a very wonderful, and I advertised it on my Hebrew page, and somebody was like, "We want to get the book in Hebrew," so I'm going to be working on that, trying to get the book translated to Hebrew.
That's awesome.
Because it's just, and the woman said there's not enough information about chronic pain in Hebrew, and it's true. Sarna's book is in Hebrew, but and then there's a Dr. Nir Brosh's book about his Sarna's story. But it is, and like you said to me when on our prep call, Danielle, you said this is the future. Like, it will affect the opioid pandemic. It will start to break through, and just little by little. So all we can do is just trust the process.
Yeah. Could I also
Absolutely.
mention about the doctors when they can't give a medication? They don't know where to move. So we can't blame the doctors, because they just don't know about the mind and the body being one, which is logical, but yeah.
And they know that. They know that.
Yeah, but they don't know how to deal with it.
Right.
Yeah.
Right.
Yeah.
Absolutely.
The
biomedical model is wonderful for structural issues and for physical issues, and it's necessary. And I think doctors are very well-intentioned and well-meaning.
That's right.
When you go to a doctor, you're looking for a structural cause. So they're going to find a structural cause. They're going to look for a structural cause. But you don't even know how many doctors come to our trainings. I would say 20% of the people that come to our trainings are doctors. So they are very well-meaning, and they're very open to this. And I think that slowly they'll become kind of allies, because we both need each other in this particular field.
Yeah.
Yeah.
Yeah. No, it's amazing. And also, Daniella, if anyone wants to be on the show, any of your colleagues, you have some lovely people in your office, we would love to talk about this from different angles, from this angle, from that angle.
Absolutely.
If somebody wants to come on with a client, I mean, we just love, I mean, we're going on our third year, and there's no stopping, Rose and I. We just love this work, and we love talking about it. And we love, talking about, because people are getting better from this work. And and I think the most important thing is that not to compare, because like, if you don't have that kind of pain, then I'm not going to get better. It's like, it's about the brain, and it's about your
that's well said. Yeah. It's about the brain.
Exactly.
Yeah. Thank you for that,
Exactly.
Tova.
Thank you.
And in honor of Dr. Sarno, think psychologically. Right, Rose? Think psychologically.
Yeah.
Yeah.
Okay.
Go ahead. My last thing I'm going to say real quick is, and Michael Galinsky comes on our show a lot, and he's just amazing. The movie was supposed to be called All the Acceptance, but he said it wasn't going to sell in the box office, so he named it All the Rage. But just remember that it's about acceptance.
Ooh.
So that's a good one. So Daniella,
All the Rage does sound more fun.
Yeah. Anyway, we'll meet again soon, and thank you so much for having lunch with us. And now go eat something so you don't faint this afternoon because you eat your lunch.
Thank you so much. This was so fun.
Yeah,
it was so fun learning from you.
The YouTube was really full of pearls of wisdom. So I'm going to send you a copy of it once we put it up with the description. And anybody that needs to speak to you or wants to work with you or wants to meet you or can, I can give them the information from Pain Psychology Center. I'm doing PRT here in Israel, and virtually Rose and I together do an incredible sous chef combination of TMS and ISTDP, and we're really, thank God, helping people. And I'm just one, we're just two blessed grandmothers, aging gracefully. Anyway, all right, I'm going to say goodbye. I'm going to go to bed. Have a great afternoon. Rose, I love you. Have a wonderful day.
All right.
And God bless.
Take care.
Thank you.
Bye-bye,
Thanks so much.
everyone. Bye.
Bye.
Okay.